Good afternoon, Dr. Hirmath.
Good afternoon.
How are you today?
Okay.
Okay. What's our topic of discussion today?
Today we'll discuss with pelvic disproportion.
This topic is of interest to you?
Like any other topic, I'll also like this topic.
Okay. You tell us about cephalopelvic disproportion.
Cephalopelvic proportion means the relationship between the size of the pelvis and the size of the fetal head. That is subrachmatic diameter.
So this
Disproportion can be disproportion can be due to a contracted pelvis or a large head. Contracted pelvis is a pelvis in which any of the essential diameters in one or more planes is so shortened as to alter the normal mechanism of labor. This is the obstetrical definition. The contracted pelvis, contraction may be at a brim. No, this is wrong. At the brim only. Only if the contraction is at the brim, these are the candidates allowed for trial of labor.
But we're not just talking about trial of labor candidates. We're just talking about the definition of contracted pelvis.
No, but here this is wrong, no?
But a contracted pelvis could be
No.
Here or here.
This is the obstetrical definition I told you, no? The contracted pelvis, contraction may be a brim. No, I don't have that notes at all. The contracted pelvis, contraction may be at brim or outlet, no. We never talk about brim outlet contraction in this. Only brim contraction here. If the contraction is at outlet, it's straight away case for suction. Understand?
But you don't know it's at the out. You don't know that it's contraction at the. So this is the brim.
Yeah.
This is the outlet. So everyone. I typed what you said your notes said.
But my notes don't say that because it's written differently. See,
because we don't just talk about contraction at the brim.
Now we can have contraction anywhere, but in this this thing,
the contraction may be at the brim or occur at the outlet.
See, but for this purpose, trial labor, we never consider contraction of outlet, only brim.
But our topic is CPD. Our topic is not just trial labor CPD. Our topic is CPD.
CPD, but in CPD.
So we have to comprehensively cover everything.
Okay.
So CPD could happen for a contracted brim. CPD could also happen
At
for a
outlet.
contraction outlet.
Pure outlet contraction is uncommon. Anatomical definition is pelvis in which any diameter of the inlet or outlet is shortened by more than 0.5 centimeters. Any of the diameters of the three planes is less than 10.15 centimeter. Disproportion, a state of wrong proportion due to pelvis being smaller than the fetal head, or the same effect occurs when the head being larger than the pelvis. Etiology of contracted pelvis. Socioeconomic and genetic factors influence the pelvic shape. Dietary deficiency, deficiency of calcium and vitamin D, that is rickets, resulting in osteomalacia, softening of the bones. Bones yield in an exaggerated manner to the stresses of body weight and muscular action, which occur during childhood. Downward pressure through the vertebral column and lateral and upward pressure from either side of the femora. The chief effects of the pressure normally is that the sacral promontory is pressed forwards and downwards towards the direction of the pubes, pubic symphysis, which shortens the conjugate diameters, and the ala are bent outwards, which lengthens the transverse diameter. This occurs when the child is below 2 years. A rickety flat pelvis occurs before the child walks. Sacral promontory,
What is rickety pelvis?
there in rickety pelvis, sacral promontory is pushed forwards by pressure of body weight.
Not the show.
This is pushed forwards. This pressure of body weight will push this, because the bones are soft. Sacral promontory pushed forwards by pressure of body weight, so conjugate diameter is reduced. Conjugate is sacral promontory to symphysis pubis. Conjugate diameter is increased due to the body weight transmitted to the iliac bones through the hip joints to the legs and lateral pelvic bone, bulge outwards, and increases the transverse diameter of the brim.
So this diameter gets lengthened. This gets shortened, this gets lengthened, so it's like hot dog shape. Kidney shape.
In the pelvic cavity, sacrum flattens or can become convex. Outlet transverse diameter is increased because ischial tuberosities are carried outwards because the transmission of the body weight. AP diameter is increased because the lower part of the sacrum and coccyx is pushed back. They're pushed back, so there's increase.
So it becomes reniform, Canadian shape. Is this common, rickety pelvis?
No,
No, no longer very common.
not at all common. Only contraction at brim that also is rare. Occasionally, if we get that, then
What is
scolio-rickety pelvis? This is more common than rickety pelvis. In addition, lateral curves of the spine produce further deformities. Sacral promontory is pushed over to one side. Errors of development. Other causes for contracted pelvis. Errors of development. Disease and tumors of the pelvic bones and joints. For example, tuberculosis. Accidents involving vertebral column, lower limb, and coccyx. Deformities of or disease of spinal column, scoliosis, spondylosis. Deformities resulting from the lower limbs. In milder varieties of rickets, only epidiameter is reduced. So these are the candidates that can go for trial of labor. Osteomalacia pelvis, caused by deficiency of phosphorus, vitamin D and calcium in childhood.
Adulthood or childhood?
In childhood. These deficiencies are there in childhood. This osteomalacia pelvis.
I thought it was adulthood because you go on to say the onset of the disease is gradual, usually multigravida.
This osteomalacia is common
in
in
adults and rickets in children. Osteomalacia in adults and rickets in children.
children rickets.
Yeah, and osteomalacia adults.
Osteomalacia adults.
Yeah. So you just said children. So we're talking about osteomalacia here.
No, that is the same cause. Calcium deficiency, vitamin D deficiency will cause either rickets, that is in children,
Right.
osteomalacia in adults.
Right, but you just said this was in childhood. This is adult. Osteomalacia is adulthood. Onset in adulthood. Because
In adulthood.
yeah. That's what you have dictated. So rickets is a disease of childhood.
In childhood only.
Osteomalacia is a disease
Adults,
of adulthood.
adults.
Yeah, so make sure you say adulthood. Because osteomalacia is a deficiency throughout life into adulthood. Onset of disease is gradual, but usually in multigravid women.
Yeah,
Yeah.
I didn't understand you.
You said in childhood.
Where?
When you read this sentence, you said childhood.
Now?
Mm-hmm.
Adulthood I told, no?
I mean, we have video of it. We can watch it and record it. I'm just asking you to read the sentence again and say adulthood.
In adulthood, and calcium the deficiency is caused by phosphorus, vitamin D deficiency, and calcium deficiency in adulthood.
Right.
Adulthood.
Right.
Then,
The first time you said it, you said childhood.
that way, that is, childhood also is common rickets.
Well, we already talked about rickets. Now we're talking about osteomalacia.
This is no just a short. It's not a topic for of osteomalacia. It's in short.
Okay, just read the paragraph and move on.
Onset of disease is gradual, usually multigravida. Initially, but this is not concerned with child labor.
I know.
Initially, during pregnancy, pain in the back and limbs and muscular weakness, and sometimes tetany occurs. These symptoms may disappear after labor and lactation to return again with increased severity in a subsequent pregnancy. The bones, as a result of softening, bend according to the direction of the forces transmitted through them. The deformity produced is a triradiate pelvis, sacral promontory pushed downwards and forwards, lateral pelvic walls pushed inwards, anterior wall pushed out of in the form of a beak, and the brim forms a trifoliate shape with subpubic arch significantly narrowed. Acetabular loop more forward, and the brim forms a trifoliate shape and subpubic arch significantly narrowed. Acetabular loop more forward. Leg joints are brought closer, and patients have a peculiar swinging gait from the muscles of legs dragging in from their attachments. A marked curving of the iliac crest.
This is also rare. Nowadays, this is rare.
Better nutrition and better standard of living in early life and eradication of rickets have resulted in a decreased incidence of contracted pelvis now. Mid cavity contraction. Transverse diameter is less than 10 centimeters. That is bispinous diameter in the mid cavity is less than 10 centimeters. Outlet contraction AP less than 10 centimeters. So for outlet contraction, the mode of delivery is cesarean section, and if the baby is dead, symphysiotomy. Not if the baby is dead, or symphysiotomy. Management of labor and contracted pelvis. 2 degrees of CPD at the brim. First degree borderline CPD. Parietal bone fushes with the anterior surface of the parietal bone. First degree of borderline CPD, parietal bone flushes with the anterior surface of the symphysis pubis. This amounts to about 1/4 inch of overlap. The AP diameter of inlet is around 9 to 9.5 centimeter. Trial labor can be given. Second degree, that's major degree disproportion. AP diameter of inlet is between 6 to 9 centimeters. If head is felt by thumb to override the symphysis pubis on internal examination. That is a major degree CPD. Methods of management. Caesarean section, trial of labor, craniotomy if baby is dead or hydrocephalus, symphysiotomy. Trial of labor indicated when the brim is of borderline contraction. Definition. Trial of labor is to allow for vaginal delivery in a case of borderline CPD at the brim, with the fetus presenting by vertex. Breech cannot be allowed for trial of labor because no molding occurs in breech. It should be conducted in a well-equipped institution for facilities with facilities for cesarean section and under supervision of a qualified obstetrician. The cesarean section has to be kept in ready because if need arises immediately, C-section is warranted. Aim of trial labor: avoiding an unnecessary C-section, but at the same time delivering a living undamaged child. Principle of trial labor: allowing for vaginal delivery, we are giving time for folding of the fetal head. After molding, the diameter is decreased or the head may be able to pass through the pelvis. The other factor that helps in giving of the pelvis, which occurs during labor. After molding and giving in of the pelvis, vaginal delivery may be possible. However, we cannot allow for excessive molding as brain damage may occur. Not beyond 4 millimeters because intracranial damage takes place. Excessive molding is beyond 4 millimeters. Beyond 9 centimeters, obstetric conjugate, trial labor cannot be given because excessive molding occurs. What is trial labor? Trial is given to the fetal head to see if after molding the head can navigate through the pelvis. Selection of cases is very important. Borderline contraction at the brim, no android features. Android pelvis is unfavorable for trial of labor due to multidimensional contraction in this type of pelvis. And rule out mid-cavity and outlet contraction.
You forgot one important sentence. The patient has to be motivated and psychological support is necessary.
The trial labor, that's very important. Patient has to be treated and psychological support is necessary. Contraindications for trial of labor: borderline CPD with maternal disease like diabetes, cardiac disease, toxemia, borderline CPD in elderly primary, borderline CPD with post-maturity because no molding is difficult here. Any abnormal presentation, breech, shoulder, brow, face. Associated mid-cavity and outlet contraction is contraindicated. A conception after many years of married life, that's after infertility, cord presentation, especially early in labor. These are contraindications. How is trial labor conducted? Patient is delivered in a well-equipped hospital. Management of trial of labor requires careful supervision and consideration. C-section may be employed at any stage of labor. Labor should ideally have a spontaneous onset, but in those cases, if labor fails to start even at term, induction may be contemplated. Patient must be psychologically prepared, and gaining her confidence is essential for a successful trial of labor. She should not be told beforehand about any doubt about the delivery. At the onset of labor, vaginal examination is indicated. The main purpose is to rule out cord presentation and to know the dilatation of the cervix and station of the head, and presence or absence of membranes. Sedation given only when labor is well established. No solid food. Patient should be examined frequently, every 30 minutes. Hydration, output, contraction, frequency, strength have to be noted. If uterine inertia is present, start syntocinon because good uterine contractions are a must for a successful trial of labor. If membranes rupture early, perform a PV to ensure cord has not prolapsed. If cord is present, emergency C-section must be done. The real test of labor, whether the head is going to pass through starts after the rupture of membranes. Once the membranes rupture, observe the patient more carefully. Signs of favorable progress: fixation and descent of the head, progressive uterine, good uterine contraction, effaced cervix with fetal head well applied, shape of the pelvis flat, no mid-cavity contraction, anterior vertex position, absence of fetal distress. When these are present, trial of labor is most always successful, and in that vaginal delivery can be effective with safety of mother and child. Signs of unfavorable progress: weak uterine contraction, slow descent of the head, uneffaced cervix, undilated cervix, hanging loose head, and not well applied to the
So
head.
an unfaced, partially dilated cervix that's hanging loose.
Not
The
well
head is
applied
not
to the
well
head.
applied.
If such findings are present, most cases
Also,
will
occipital posterior position.
posterior position.
That's important. Baby's position is important.
If such findings are present, most cases will end up in section. How long to continue of trial of labor? If there is no progress in labor despite good uterine contractions for 6 hours, then end the trial and delivery by section.
We spoke about that, induction is not preferred, but it's an option. But we didn't talk about augmentation. Yes, you had mentioned
Augmentation,
that augmentation is fine.
Yeah. If uterine contractions are not good, you have to, because good uterine contractions are a must for trial of labor.
Right. I just want to. You didn't mention that, so I'm reminding you.
I didn't mention.
You didn't mention that Syntocinon is okay to be administered in trial of labor for CPD.
But I told somewhere, no?
You said good uterine contractions, but you didn't say what to do if they're not good.
If they're not good, obviously this symptom has to be started. I didn't tell that.
I'm more interested in. We had spoke about before the
Symphysis.
yeah, which is no longer really done anymore, unless maybe they're in a rural setting.
In very remote areas in African countries, it may be done. We have not. No, we have seen a case in KMC also.
One
Case.
you've only done one symphysis?
One the symphysis was done.
You did it?
I assisted.
But now no.
No. Now every tendency is for C-section, no?
Okay. Should I stop recording?
You didn't record all this time.
I know. Should I stop?
Stop it.